Right. Welcome and thank you to you all for being here. Just to start with, there's going to be a Q&A at the end, so feel free to drop in some questions to the Q&A box at the bottom of the chat there, and I'll try my best to answer or address them as we go through. So, firstly, to introduce myself, my name's Simon Reed, and I'm a social researcher with a background of interest in medication adherence, particularly with chronic conditions, as well as behavioural change and preventative health and social care more broadly. That spanned a number of different conditions, including ophthalmic ones like glaucoma and age-related macular degeneration, as well as neurological conditions like dementia, as well as how multiple conditions can combine to create further complexity when patients are tasked with taking ongoing medication. I should note right now that I haven't had many interactions with dental conditions over time, but then there hasn't been a great deal of work done on medication adherence in that context anyway. So I'll be looking to demonstrate some of the broad brushstrokes which I believe are applicable across medical specialisms, as well as thinking through how these general principles can be applied in dentistry more specifically. This will require me extracting some of the key general messages associated with adherence to prescriptions and seeing how they operate within the realm that you work within. In this webinar, I'll be predominantly talking through healthcare-related medication adherence, and that's the taking of prescribed drugs as outlined by clinicians. Though as I'll talk through, there are lessons to be learned from all manner of other interventions and initiatives in the realm of public health, social care, and beyond. In terms of a rough outline, firstly, I'll give you an overview of medication adherence, why it's important, as well as how it's defined. And from there, I'll look at how the COM-B model of behavioral change is being applied in relation to the common barriers associated with prescribing new medications. I'll also look at ways we can try and improve medication adherence at the initiation of a new prescription, as well as common barriers when attempting to modify or change them. And finally, I'll talk through taste in terms of its role in adherence to relevant prescriptions. So what is medication adherence and why is it important? Well, adherence has long been established as a confounding, elusive, and potentially costly factor in the management of chronic conditions. But firstly, for clarity, it's worth outlining how adherence has been defined by the World Health Organization. And that says the extent to which a person's behavior, taking medication, following a diet, and/or executing lifestyle changes corresponds with agreed recommendations from a healthcare provider. And as you can see, that definition is relatively broad and includes non-medication related healthcare instructions, such as dietary changes. I'll be mainly focusing on research into medications, as I say, but we'll naturally be dipping into these examples from these other worlds because I think some of them bear some relevance to dentistry more than anything else. The WHO are also helpful in providing 5 dimensions of adherence: condition-related, healthcare system-related, social and economic factors, therapy-related, and patient-related, which I'll be using alongside other models as we progress through. The introduction of a new lifelong medication for a patient is asking a behavioral change of them. And understanding their individual behavioral resistance, the role of clinicians in negotiating and supporting patients in this process, as well as the more systemic organizational barriers, both generally and condition specific, is pivotal in ensuring patients follow their regime. Something important to note as well, specific to dentistry, is that, as I kind of alluded to it already, but it has its own existence in the periphery of medication. So some of the toothpaste are being prescribed, but a lot of it relies on learned self-care, also dependent on adherence, such as toothpaste and flossing. So what is the scale of the problem and what are its consequences? Looking into the UK context, one large-scale recent UK study was the Aston Medication Adherence Study, and that was conducted by researchers at Aston University's Pharmacy School. It was one of the first large-scale real investigations into medication adherence in the UK, and that study incorporated 1 million anonymized individual prescriptions, conducted more than 7,000 patient questionnaires, around 7 separate focus groups to look into why patients stopped taking their drugs in 3 clinical areas, those being raised cholesterol, type 2 diabetes, and hypothyroidism. The results demonstrated once more the significance of the issue, with around 1/4 to 1/3 of patients being non-adherent. Looking more globally, several rigorous reviews prior to the WHO publication on adherence to long-term therapies in 2003 highlighted that in developed countries, the adherence rate for chronic conditions averaged at around 50%. While many studies have shown significant variation on that based on condition, how long a medication has been taken for, and various other factors, most have also demonstrated consistent issues with adherence regardless. Why does this matter? Well, in terms of medication particularly, the issue of adherence is more confounding, given that it can be hard to disentangle whether detected physiological deterioration or condition progression are due to decreased pharmacological efficacy or due to medicine just not being taken. As such, there are multiple negative effects associated with it, which the WHO cite as being suboptimal condition management, reduced clinical benefits and quality of life for patients, wastage of healthcare and clinical resources, and ultimately long-term health economic costs. Now, I don't want to delve too deeply into the health economic side of things, but it is worth outlining some of the perceived costs associated with medication adherence. Within the UK, recent estimates and quotes from former Health Minister Jeremy Hunt place the cost of adherence-related medicine wastage as up to £500 million per year. But that wastage of resources is compounded by further issues around the cost effectiveness of the prescribed drugs. Some good examples are the prescription of bisphosphonates for osteoporosis, which is a relatively inexpensive way of preventing condition deterioration if taken as prescribed. If not, though, the costs of treating a subsequent hip fracture may be up to £20,000 from the NHS on top of the ongoing provision of those drugs. From my own personal experience of doing interviews with glaucoma patients with carrier bags full of eye drop medication that should be preventing their blindness, and also having seen many of these same patients suffer serious sight impairment over time, there are also knock-on costs at other parts of the health and social care sector from the more extreme ends of these spectrums. One of the most recent pieces of work quoted on the slide here just now is Cutler et al., who performed a review of 66 studies from a range of developed countries such as the USA, Australia, and a few EU countries too. Their report highlighted that across various chronic conditions, the adherence costs incurred per patient per year could vary from $949 to $52,341 once costs were adjusted. To take this into the dental sphere, one example is Caries, which prescribes relatively cheap, high fluoride toothpaste, but with non-adherence factored in, could see significant additional costs in treating the condition as it progresses, ultimately towards tooth loss and the further costs associated with that. As important as the costs in terms of healthcare provision, though, are the potential costs for patients associated with progression and further treatment, which may exclude those with less income. Unfortunately, as with many issues,
I'll come back in a minute. Yeah, thank you.
Non-adherence in the first instance. So these tend to compound an already complicated issue. Okay. So there have been several ways of thinking of and conceiving of and approaching medication adherence. Starting most broadly, one of the more convincing viewpoints on adherence to chronic conditions is as a continuum, beginning at the point of prescription and continuing often for an entire lifetime. Following the WHO report in 2003, there was a growing research emphasis on trying to uncover the reasons that people had for not following their healthcare advice. And one notable study, which I've gone back to many times, was that of Pandora Pound et al., which looked at these issues qualitatively and offered a new model or typology of adherence states which patients could be categorized into. These included active acceptors who were wholly engaged with the process, passive acceptors who accepted it but tended to rely on others to aid them or were less actively engaged with their regime, those who were actively engaged but for various reasons felt the need to modify their regime, as well as those who resisted or rejected it altogether. Another helpful study offering alternative ways of thinking about the adherence journey was that of Regens et al., who looked to develop a standardized taxonomy of adherence. And that involved seeing the commencement of the prescription and the first dose as being the initiation, adherence itself as a form of implementation of the regime successfully, with persistence to that being the key, and then discontinuation marking the last dose. That's helpful in assigning us all a common language to work with. Again, though, for most chronic conditions, the point of clinical discontinuation may never materialize, meaning that the period of persistence can be extremely long. The assumption that it will be maintained completely has been shown to be evidentially incorrect. Even for those who at one point are deemed as actively accepting their medication, that can't be guaranteed over the course of their lifetime. I've published on this topic in relation to dementia and how this can mark a transition in states of adherence from active to passive. But I think similar transitions are happening much more often and intermittently. Finally, a model that I find particularly useful in explaining adherence is the COM-B model of behavioral change, which I think you may well be familiar with through the Delivering Better Oral Health Toolkit and paper. Though the COM-B emerged most notably in relation to public health initiatives, as I've outlined at the start, there are significant overlaps in the intended outcomes of these initiatives and that of prescribing medicine for chronic conditions. They are ultimately looking to instill a behavioral change that will ideally be there for a lifetime. The COM-B model proposes that the barriers to behavioral change are split, albeit with significant interdependency, into categories of capability, opportunity, and motivation. The aggregated effect of these, how well these barriers are mitigated, how well the behavioral change is supported by clinicians and the systems around the medicine, that's all going to influence the desired behavior. So I'll just unpack this a little bit more. Apologies if you are already familiar with it, but I do feel like it's a really helpful thing to do. So capability is referring to either physical or psychological issues that can inhibit an individual in taking their medication as prescribed. Some examples from my own work are with the tiny eye drop bottles that are prescribed for glaucoma and maintaining or lowering intraocular pressure. Given that a large percentage of glaucoma patients are aged over 65, there's also an increased likelihood of them suffering another comorbidity that impedes daily installation of their drops, the most common in this instance being arthritis. Another factor from my own research is dementia or memory problems or depression that can render some incapable of remembering to take their medication, more so if there are other comorbidities complicating that regime or subjectively taking priority, which also links to these issues of polypharmacy as well. So barriers of opportunity are more common than most, and these are the more systemic, structural, and other external influences to the individual that may inhibit their ability to start or maintain a new medication. The most common examples are linked to prescription problems, either not being able to have them fulfilled due to pharmacy stock or unavailability of repeat prescriptions, or a lack of understanding of what the regime is and when initiation should start. I like to think of this part of the model not so much as being a barrier to adherence, but as a means for clinicians and the wider healthcare system to identify their role in ensuring that some of the more frustrating but most common stumbling blocks can be overcome prior to initiation. Providing or maximizing the opportunity for people to engage with their prescription through clear information and education on the condition are just some of the things that I'll come to talk about later on. And then finally, and the big one for a sociologist, is motivation, which is, as you can imagine, quite a multifaceted and complex aspect. But it's also really good in demonstrating how the categories do interlink with one another. Issues of capability and opportunity can directly influence an individual's motivation, and from a patient's perspective, it's also evident that their motivation can influence their capability and so on. Forgetfulness is a good example, as it could be rooted in any of these areas, really. It's the fairly common face of motivational issues, but also attributable to capability through dementia or opportunity if the regime has not been clearly described. Again, as I'll discuss in more depth later on, it's becoming increasingly clear that a key part of a clinician's role in providing opportunity is through engaging with patients and ensuring they are adequately motivated to do what they need to do. Some of the most commonly expressed motivational issues are around side effects or the fear of them, belief that the medication will help, and relatedly, the perceived seriousness of the condition. Cultural differences and variations are also increasingly seen as a key component of some motivational issues too, and those are often interlinked with some of those already listed above. Okay, so outlining the barriers to adherence in more depth. A recent systematic review on the topic highlighted 58 separate barriers referenced in relation to chronic conditions. That's from Devine et al. Of those, the study highlighted some of the most commonly cited as being those listed here, which have been recurrent features in most adherence research for the last 20 years or so. These are all as relevant at the initiation of a new prescription, perhaps even more so than they are later on. Firstly, there are pre-existing physical or psychological issues, the most common being depression, which would commonly be cited as primary barriers for patients to overcome, predominantly impinging on their motivation to engage with their prescription. Naturally, being aware of any such issues or indeed physical problems that may also inhibit adherence behaviors at the point of prescription may not always be possible, but looking to establish them where you can is hugely important. In terms of eye drops and glaucoma, the relatively common issue of arthritis may impede in terms of raising one's arm high enough to instill a drop. Likewise, when prescribing a new toothpaste, consideration of whether there are any issues that may inhibit the capability to get a toothbrush into mouths needs to be made. More specific to new medication is the fact that at the point of being prescribed, the patient is fairly likely to have a limited knowledge or understanding of the condition that's being treated and its potential consequences, as well as the prescription and its intended regime. These can often intertwine with broader health literacy issues, which can often then in turn commonly be entwined with a distrust of health services or of doctors. Other commonly reported factors are concerns over the potential for side effects ahead of new medication being taken, as well as fears of the medication itself or its administration, such as swallowing pills or painful eye drops, alongside the fact that introducing a new medication requires its embedding into pre-existing daily routines and subsequently has a high likelihood of being forgotten or put to one side. All or any of these barriers cited on this slide can be seen as capability or motivational barriers predominantly, although the last one around prescription unavailability or a perceived state of polypharmacy hints at some of the systemic barriers that also need to be mitigated. Aside from that, though, there's been a recent emphasis on the role of the clinician in attempting to overcome these hurdles, and any efforts in this regard are best placed at the initiation of a new prescription. One thing worth noting in relation to the prescription of a new toothpaste, as one would do with a condition like caries, is the extent to which it is contradicting pre-existing routines and habits. For instance, the guidance specifically states that some high fluoride toothpaste should be used 3 times a day, which may be a difficult adjustment for patients to make if trained to do things in the morning and the evening. Likewise, related changes in how long one should brush for, the frequency of brushing and technique required, and any other elements of successful administration that differ from what is being done already. These are all things that clinicians need to be conscious to convey. Okay, so when thinking about what clinicians can do to aid adherence, it's helpful to think back to the COM-B model, and particularly the opportunity element, so as to view the clinician's role of maximizing patient opportunity to engage with their prescription and minimizing the barriers they may experience along the way. As I've said throughout, the COM-B model is highly interdependent, so naturally this will involve mitigating any individual issues of motivation or capability, as well as ensuring to the best of your ability that all the organizational or structural barriers to ensuring that prescription is fulfilled and enacted are also fairly easily navigable. On receiving news that they have a chronic condition, as distressing as that may be for a patient, it represents the ripest opportunity to engage with them and begin to address some of the more common barriers listed out in the previous slides. As clinicians, physical capability issues may or may not be evident during the consultation, but inquiring around how medication management would work for patients where there are concerns like this should be second nature. However, based on my own research observations, that isn't always assured. To help break this down, one old school way of categorizing adherence interventions that can be applied by clinicians is the simple mnemonic, which is outlined here on the slide, and which I'll go into more depth in the next one, but broadly consists of simplifying the regimen, imparting knowledge or education, modifying pre-existing patient beliefs, patient and family communication, leaving the bias or assumptions behind, and evaluating adherence. I should note that most of the evidence on the success of adherence interventions is patchy and inconsistent overall. To quote the NICE guidelines, be aware that although adherence can be improved, no specific intervention can be recommended for all patients. Tailor any intervention to increase adherence to the specific difficulties with adherence the patient is experiencing. That said, there are several things which seem to be helpful for some, though inevitably not all patients. Some of the more convincing results have come when running some of the simple ideas concurrently with one another, suggesting that a multi-pronged approach to the use of interventions may be the most likely to succeed. Certainly, Costa et al. Cited several studies as part of their relatively recent review, which saw education initiatives working particularly well alongside behavioral interventions looking at promoting healthy behaviors and physical activity. In short, though, based on the lack of conclusive evidence on medication adherence, even espoused by the NICE guidelines on the topic, the best practice is to reflect on your interactions and think back as to whether you've done your best to remove as many obstacles as you possibly can, while simultaneously offering the best possible support to engage patients with their medication. So just going back to the simple categorization, I want to offer you a little bit more granularity on what kind of interventions we're talking about here and how they work in terms of adherence. So in terms of simplifying a regime, some of the specific activities a clinician may attempt would involve adjusting characteristics of the dosage, such as timing, frequency, and so on, wherever possible so that it best matches patients' daily lives. Going back to my studies in ophthalmic adherence, eye drops are notoriously awkward given they exist outside of other medication taking activities and are often best used just before bedtime. When faced with non-adherence to this particular routine, though, clinicians should think about how best to integrate a different routine that may not maximize the clinical benefit to the same degree, but better entwine into people's lives. Funnily enough, eye drops and brushing one's teeth are commonly grouped together, and so it feels to me that both medicine-taking activities share that characteristic of being almost peripheral to some of the more common adherence aids, like pill boxes, which are normally very helpful in managing medication and handling capability issues such as polypharmacy. Okay, and then on to imparting knowledge. And I think this is kind of shared with modifying patient beliefs in many respects. They do entwine in a lot of ways. When prescribing a new medication, patients should be well informed of the condition being treated, what the medication is likely to do, side effects and their likelihood, how best to use it, and so on. This can be done verbally or through the provision of leaflets or pamphlets, or in certain cases through online health education. Ultimately, the purpose of that education is to offer patients the best information to inform their decision making. But also, if some are predisposed to feeling the condition is not that severe, or that they are less likely to suffer the worst case scenario, as may well be the case with conditions of a largely behavioral nature like caries, this should be assessed and addressed by the clinician. For glaucoma, the progression of the condition is relatively asymptomatic until the latter stages. So a lot of the work is in convincing patients in the early days that it is a genuine problem. Some elements of risk communication can be often gently introduced here so that the threat of the condition progression is fully perceived. The last point there under modifying beliefs is around rewarding, tailoring, and contingency contracting, which are all alluding to behavioral interventions that may be used when beliefs around medication or condition mean they are deprioritized or of limited concern. I won't dwell on them too long as they are based in the realm of patient education and communication in any case, largely, which moving on to, we have here. Now, I'd say this deals, again, more with how clinicians can communicate best with patients, including being verbally clear and concise, listening to patient concerns and addressing them, and including them in a decision-making process around how best to manage their medication. This should also take into account any specific obstacles they have that may compromise their capability. To mitigate these, particularly in terms of forgetfulness, some helpful interventions include reminders via text, mail, or email scheduled in liaison with the patient. More broadly, all of these points edge towards making patients' care as convenient as possible, and this ties back to issues of opportunity as well. Issues with the initial filling of prescriptions can commonly be mitigated by clearly outlining where they can be dispensed, when to commence treatment, and the scheduling of a defined follow-up period, which may well be shortened if there are particular concerns around a patient's likelihood to be adherent. Also, one other point, training nurses or other healthcare professionals to perform some of these tasks can be incredibly helpful in terms of time allocation for clinicians. There have been numerous studies where interventional roles or adherence counseling are performed not by doctors, ophthalmologists, or dentists, but by other staff after a prescription has been provided as another form of education. For instance, in the prescription of eye drops once more, we found that an ophthalmic nurse offering training in how best an individual can take them is a good checkpoint, not only for that practice, but to ensure capability is in place. Based on the relatively complex instructions of the medicinal toothpaste for caries, similar sorts of interventions sound like they may be a good fit. For instance, providing an indication of the speed and motion of the optimum technique, how much should be used on the brush, and other factors that may provoke confusion in light of previously learned behaviors. So on to leaving the bias. I always found this one named rather strangely because it's almost like it's just trying to fit in with the mnemonic as opposed to making sure it's crystal clear what it actually means. But this is pointing towards similar ideas around tailoring clinical communication to an appropriate level for the patient. As a sociologist observing eye care appointments, I was taken aback initially by some of the linguistic complexity, which was completely alien to me around the condition at that time. And I'm pretty sure that if I was a patient in that room, I wouldn't have understood what was being communicated. Also, it's important to leave assumptions of knowledge and shared beliefs behind. Most of the techniques or interventions I've mentioned are in place to gain an understanding of whether a patient truly grasps their condition, whether they're able to manage their medication, and if there are any suspected barriers to that. As I say, it seems particularly common based on my ethnographic observations that the delivery of clinicians is variable, and therefore, so integrating some form of checklist of activities into your appointments where new prescriptions are introduced can be a valuable tool. The appointments that I've observed and felt to have been the optimum have followed a tailored protocol while offering enough flexibility for patients to highlight their issues and demonstrate their capability, ensure that they have adequate opportunity to manage their medication and that they are motivated to do so as well. On to the last one, which is evaluating adherence, which is important. I won't dwell on most of this too much in terms of adherence research tools like the medicine event monitoring systems or prescription refill data, pill counting, and so on. These are all deployed to assess adherence both individually and in the context of population-wide adherence rates as well. But one element that I do feel is very important in terms of the persistence of a prescription is the follow-up appointments and the use of adherence checks within them. Again, deferring back to my work in ophthalmology, many of the follow-up appointment questions, once a patient has been prescribed drops, have evolved in practice over time, but are guided by the use of open-ended questions, such as, could you tell me how many times you take your eye drops each day? And how often do you think you miss an eye drop every month? As opposed to the simple close-ended questions, do you take your drops every day? Obviously, this is still self-reported adherence, which is notoriously inaccurate whenever it's been tested more rigorously. But the use of more targeted questions, if nothing else, can elicit more telling responses and guide your next steps. So a lot of the adherence interventions I've talked through in the last couple of slides are orientated towards the early days of a new prescription, which, as I mentioned, is a key time to engage with patients and instill some of the beliefs you would hope them to have around the condition. This, though, is just a fraction of the problem when it comes to adherence in chronic conditions. Referring back to Region's taxonomy of adherence, while the initiation period is fundamental in putting those building blocks in place for a lifetime of adherence to medication, an equally complex problem is ensuring that patients are persistent with these regimens over very lengthy periods of times or indeed lifetimes. Evaluating adherence becomes a key part of this process as implementation proceeds and persistence to the regime becomes inevitably lengthier. Follow-up appointments offer opportunities once more to engage with the patient and attempt to gauge the scale of any adherence issues in a very non-judgmental way. As I mentioned in the previous slides, the manner of inquiry is as important as anything else. Carefully worded adherence check questions specific to your context can tease out clues as to whether there may be problems, what these may be, and how clinicians can help them to be negotiated more fully. NICE recommends inquiring about whether any doses have been missed and doing so in a way that doesn't apportion blame, explains why the question is being asked, mentions a specific time period, such as a week or a month, and inquires around any modifications that may have been made to the suggested dose. I said near the start that unpicking adherence issues from a diminished pharmacological effect is incredibly difficult at a clinical level for many conditions without there being clear, honest dialogue with the patients. It's in these situations where there is a lack of clarity that either a change in medication is required or further adherence interventions such as additional training on medication management, use of reminders and so on need to be integrated. Naturally, rather than assume non-adherence in such instances, the default clinical position based on patient safety will be to change the medicine, as outlined near the start in relation to the health economics of adherence, though this isn't an ideal outcome if it is actually due to adherence issues. The guidelines also emphasize the importance of recognizing that most patients are non-adherent at certain points, and identifying and addressing these fluctuations need to be done in partnership. Some of the common causes for fluctuations are unexpected life events, such as family members or pets dying, with links to potential depressive behaviors, as well as there being expected but confounding disruptions like going on holiday, which just generally disrupt embedded routines. Similarly, there may be changes in mood or the perception of the condition more widely that lead to bouts of non-adherence. One way in which this is manifested in my own research is with the onset of other comorbidities that either compromise physical and memory-based aspects of adherence, or result in one condition being deprioritized amidst many others. Finally, there are also the development of side effects by patients. And again, it's important to recognize that these are perceived by the patient and are substantial barriers. In ophthalmology, the feeling of an eye drop going onto one's eye can often be quite gritty and deters many from persisting with it over time. And for some, these side effects may only begin some period into implementation, whilst for others, they are there right at the initiation. It's also important to recognize on that note that although side effects may not realistically be linked to a form of medication sometimes, they can still provoke a distrust of it that will require redressing. One example came in a recent study where a chap newly enrolled onto some standard first-line eye drops felt that they were giving him heart tremors, which was deemed physiologically very unlikely, but left him unwilling to continue with them regardless. Likewise, another patient told me of them discontinuing their glaucoma drops because he thought they were responsible for his eyes watering when he played golf, which was again quite unlikely, but enough to deter him until that behavior was addressed by an optometrist. So I'll just talk through some of the barriers when changing medication specifically, because there are some different overlaps and various deviations too. And sometimes changing a patient's prescription is just literally the only safe pathway that a clinician can take. So as I said, though, this does introduce another layer of problems, and some of these are more or less exactly the same as one might expect when starting a new one, a medication. The key difference, though, is the pathway that the patient has taken to get there and how much of that you can decipher as a clinician. So, for instance, if the cause of the medication change is known to be an adherence problem, the starting point for you as clinician may be different to that if you were fairly sure it is pharmacological in origin. This becomes clear when we talk through some of the common barriers to a change in prescription. The first point on the slide here is that there may be changes to routine, additional dosing required, more frequent administration, and so on. As I mentioned, I feel this would be a fairly common aspect as it relates to prescribing toothpaste for caries or other dental conditions. It's likely there will be pre-existing habits and routines associated with using standard paste that may require unpicking, and with many determinants of the condition likely to be behavioral, there may also just be more broader issues to overcome. If changes to the medication here are being done as a response to an adherence issue, such as the complexity of the regime being too much for the patient, a further increase in complexity will only make matters worse. If there are pre-existing beliefs or behaviors that have contributed to condition progression by affecting adherence, failure to address these through some form of intervention will see further medication changes in the future. If, however, it is due to diminished pharmacological effect with the previous medication, patients may well be more likely to adapt their behaviors if they're committed to medicating that condition. Naturally, though, in both instances, your support as a clinician in identifying and navigating these issues is paramount. Commonly, I've observed ophthalmologists and optometrists make amendments to regimes which uproot existing patterns of behavior, and I've noted how difficult patients find that during interviews afterwards. Any help for patients to modify the regime to fit in with them or to train them in new required techniques, offer reminders, and all of those other interventions I've mentioned previously will always be helpful from either you or another member of your care team. The fear of side effects is an ever-present one whenever someone is taken on new or changed medication. Again, though, the patient pathway and how they reach this checkpoint needs to always be considered. Is the change of medication provoked by adherence issues that could already be attributed to side effects? If so, patients may be more wary of trying something new and need some clear communication and encouragement, and sometimes even alternative medications or forms of treatment. In such instances, again, clearly discussing this in partnership with the patient is key, and working out a co-produced solution based on how both of you perceive the situation has been shown to be the most effective means of tackling adherence, really. Naturally, this should be the case whenever one is introducing a new medication. If there are pre-existing concerns over adherence behaviors and the reasons underlying them, then these should almost certainly factor into your approach. Again, As with the introduction of new medicines, when reviewing or changing it, there should be an assessment of whether the patient has any opportunity barriers to initiating and maintaining this new regime. Is it widely available at local pharmacies? Is it affordable for them if they are paying for their prescriptions? Likewise, these medicine reviews or follow-ups are perfect opportunities for checking on whether there have been any noticeable fluctuations around issues of capability, education, or beliefs around the condition. Over time, as it's said in the NICE guidelines, patients are highly likely to modify their regime and see if it affects their symptoms, deviating from the agreed plan. Whatever the root of those particular adherence problems, some form of re-education on the condition is again good practice. Okay, so speaking around the palatability and specifically the taste of medication, this has a long history, even if increasingly it is restricted to certain contexts. Obviously, this purely relates to oral medication of any kind, and I'm sure we've all had some bitter pills to swallow at some point in our lives. Sometimes the palatability of medicines can stretch beyond purely the taste to include the size of tablets or the smell of formulations and so on, as has been found in several studies relating to aversion to HIV therapy, such as Dorman et al. There, where it's cited as a key influence to adherence within questionnaires sent to those who had missed some of their doses. As the authors noted in that, the swallowability of the medicine was heavily influenced by its taste, with their participants who skipped pills being more likely to report being bothered by this, or the size or the smell of them. So in a sense, palatability and acceptability of medication are both tied to the physical experience of medicine taking and the sensory experiences associated with it. Most commonly, taste specifically is regarded as an issue in pediatric medicine, where numerous studies have highlighted it as a core problem. A recent review by Mystery and Batchelor again demonstrated this, stating that the palatability of pediatric medicines is one of the most important formulation factors in the acceptability of liquid medicines, with potential to influence adherence to therapeutic regimes and outcomes. And this point's been reiterated through various initiatives going on in that realm. One other area commonly reporting on issues of taste and adherence relates to dietary or nutritional plans. Again, adherence in this context is considerably influenced by the taste and palatability of the plan's contents, what those engaging with it are used to, and how this factors into the sensory experience of eating or drinking that prescribed regime. Demestral et al.'s study in Switzerland suggested that taste was a key variable associated with adherence, but these were also filtered through personal preferences that may be inbuilt prior to adapting to the new diet. And that reported particularly that there was a negative association with the dietary pattern associated with fruits and vegetables, but a positive one in terms of meat and dairy, as you may expect. Importantly, this suggests, though, that many of the psychological barriers associated with taste and adherence to dietary regimes can be influenced by the modification or adaptation of that prescribed regime. Interestingly, when researching the role of taste and adherence specific to dentistry, there were very limited results returned, showing it seems there may be a gap in the literature around how chronic dental conditions may be influenced by it. But given the implications for adherence outlined in these other fields already, it seems like something of an oversight that there's been little consideration of it. In terms of chronic conditions like caries, the prescribed toothpaste itself is highly likely to be a factor in patients' daily adherence. Alongside attempting to change their behaviors and habits in regard to the administration of the paste, expecting these adjustments to be performed by patients who are experiencing displeasure when using it could be expected to have some knock-on effects as to whether doses become missed, and also the development of resistance or modification of prescriptions. One of the few articles that was returned highlighted the development of a new toothpaste where considerations of taste were central by Bankova et al., though this was more around the chemical science of developing flavors that would align with the shelf life of the toothpaste. Interestingly, those flavors were tested on consumers to ascertain if they were usable for future pastes. So another recent survey performed by Colgate-Palmolive took their Durafat 5000 ppm fluoride toothpaste to patients directly. And that was in a single blinded non-interventional survey where 82 patients were asked to taste and compare this paste with another generic 5000 ppm fluoride toothpaste. This included filling out a brief scoring survey after each paste was tasted, as well as a further questionnaire comparing both toothpastes at the end. As you can see on the slide here, the results demonstrated the importance of taste preference when considering which toothpaste to prescribe patients with caries. Around 3/4 of those surveyed preferred the taste of the Colgate brand name to the studied generic. Interestingly, the patient questionnaires also highlighted that 80% of those surveyed would prefer the Colgate Durafat brand if it was prescribed as an ongoing medication, as it would be for caries. Given all of the evidence mentioned in the previous slides, it feels almost self-explanatory that taste has an influential role in adherence for oral medications. Efforts to mitigate any potential causes for behavioral resistance can vary from condition to condition, but in terms of adhering to toothpaste, taste appears to be one of the more important dimensions to me. Naturally, that doesn't account for everyone. Taste is a subjective thing, and for some, the generic may be perfectly adequate, or at the very least, a surmountable obstacle if all of the other aspects of capability, opportunity, and motivation have been put in place. But for others, this will not be so. And for me, this relates back to the clinician's role in helping to mitigate adherence obstacles and enhance the medication experience. For those perceiving it in such a way, poor tasting oral medication can be as off-putting as some of the ophthalmic side effects I've heard described to me in my research work there. For many, the stinging sensation of a frontline generic eye drop for glaucoma can be overcome if they understand the consequences of not taking it. However, for others, even that will not be enough of a deterrent to stop it. And so they will develop resistant behaviors, and this spiral of behavior will continue. In ophthalmology, in such cases where patients complain of pain or displeasure in the administration of drops, this prescription is generally changed to a preservative-free version of the same drop, which generally then alleviates the symptoms. While more costly, the benefits in the long term relating to adherence and subsequent treatment being required more than make up for that, provided adherence to the new drops is also assured. Eliminating barriers based on taste is as important as removing all of the other barriers mentioned previously. For some, it may be the most important barrier of all, while for others, it may be relatively inconsequential. Nevertheless, perceiving of the adherence issue as a complex set of interrelated barriers requires placing some of the emphasis on clinicians to help overcome these. I would argue that by pressing patients to take toothpaste that appears more likely to provoke issues of non-adherence relative to another, that's creating an unnecessary barrier for patients, provided that obviously the preferable alternatives offer the same clinical efficacy. Okay, so I'm getting towards the end. That's why I'm on the conclusions slide. I've gone through all my major points, so I'll just summarize them briefly before we go into the Q&A. Firstly, medication adherence is clearly a complex issue with the nice guidance on best practice to alleviate adherence issues unclear at best. Simultaneously, the issue in terms of health economics is a core concern across much of the world, given that non-adherence can result in significant knock-on effects and costs. Adherence research has been very helpful in unlocking the barriers to medication management, highlighting the commonality of some of them and the uniqueness of others specific to conditions or healthcare systems. However, research remains conflicted on how best to mitigate non-adherence, partially contributing to the lack of clarity in the NICE guidance. While this states that no single intervention has been shown to be effective all of the time, this doesn't need us to leave us feeling defeated. Many other studies have found a combination of adherence interventions can positively influence a patient's adherence to medication. In real terms, the best practice that remains so elusive is to integrate as many positive influences towards a patient's behavioral change while reducing the barriers. The simple tool that I talked about earlier on is again very helpful in picking out some of the more common interventions that can be performed to help with this. However, to do that, as I've said throughout, requires not just a commitment from the patients, but also from clinicians. The role that is performed by the clinical team in initiating and implementing a new prescription is paramount. The culture of blaming patients for non-adherence, as easy as it is to fall into, is no longer acceptable. Clinicians can help patients with many of these issues, not all of them all of the time, but by incorporating some of the ideas outlined into their interactions, most of the more common pitfalls can largely be avoided for most people. Finally, I just wanted to reiterate the uniqueness of adherence in dentistry, particularly. Naturally, that relates to those issues of taste and adherence I've just covered, but also because, as I've said throughout, there are some learned preventative behaviors in place that also may complicate any prescribed toothpastes or treatments. Given that adherence research in dentistry is a relatively new field, I'd expect to see some more of this complexity interrogated as time wears on, and some of the condition-related issues experienced by patients in this area to eventually become more obvious. And that's me complete. I do believe that these slides are going to be available to you afterwards. I've put in place a list of the references used in the slides there for you. If they aren't freely available, you're welcome to get in touch with me via the organisers afterwards. I do believe that there's a Q&A running as well, so I have access to some of the questions and I will take a look at them now. So there's a few here. So one of the first ones there is asking, we don't have much time to talk with patients. If only I had time for one piece of advice, what would that be? Okay, so, well, it feels a shame I've spoken for 45 minutes around it, and now that's just got to be one piece of advice. But I think if the issue is that you don't have a great deal of time to talk with patients, which I know is a common problem in most clinical activities, to be honest, I think the best piece of advice I could give would be to try and look at ways of allocating the labor amongst your team so that there are opportunities to have these kind of adherence chats with patients. They are, I would say, kind of essential in alleviating some of the problems that I've outlined during the talk. I suppose beyond that, I think just clear communication with your patients is one of the best things that you could ever have. And whenever an adherence check-in is going well, you can feel that there's a good flow to a conversation, that there's a mutual respect almost. So I think just engaging with patients at a level that's suitable for them is key. There's not a particular way of doing it. It seems to be very variable based on which patient you're seeing. But I think the other thing, like I say, is having that level of communication in place. Okay, see if I can find another question. In terms of the continuum, I feel the biggest barrier is getting the patient to visit the pharmacy to have their prescription dispensed. Any tips on helping that along? I think I mentioned some of that during the talk, and to me, I suppose it is one of the biggest stumbling blocks, and I do agree that it is a big barrier because often there is a reluctance or many other issues involved in getting a prescription filled. If it's a motivational issue that's leading to that prescription getting fulfilled, then I feel that needs to have been addressed beforehand, probably in the consultation itself, because it's obviously going to be an issue going forward. If not, then the follow-up appointment where it must be, I assume, getting fairly obvious that there's been some adherence issues, could be a good opportunity to raise that with them. Other than that, though, like I say, the systemic barriers associated with getting any prescription fulfilled have tended to be alleviated in my research by having good contacts between those who are dispensing the prescriptions and those who are dispensing ultimately the drugs. And so, having that in place and being able to give advice to a patient as to where a good place to get that particular prescription is always a good thing to have in your back pocket, I think. And certainly it feels that the whole system is a lot more connected when that is the case. Okay. You talked about affordability being a factor in adherence. Are patients more motivated to cash a prescription for multiple tubes for one cost? Right, well, especially those with caries risk linked to a chronic condition. Well, I imagine so. I mean, like I say, adherence is a very complex issue and it can be very multifaceted for individuals. So for some patients, I imagine that would be, if it's a predominant cause of their non-adherence, the fact that they can't afford the toothpaste or the prescription itself, then I'd imagine that would be one of the first things you'd go to try and resolve that adherence in the long term. It seems like a good idea if you can cash in as many as you can, if that's going to be helpful for that patient. At the same time, I have seen that being done in glaucoma, and as I mentioned in the talk, there are carrier bags full of eye drop medication, which I have observed myself, and that seems like a huge waste of resources too. So there's got to be some sort of level of pragmatism there, I think. But yes, I mean, it very much depends on the patient. You wouldn't necessarily need to do that for everybody, but it might be something valuable for some. Okay, let's see if there's any other ones. Okay, yeah, you mentioned the NICE guidance on adherence to medication was unclear. How do you think this could be improved? So, yes, I was maybe being a bit harsh on the NICE guidance. It's unclear for a reason because the evidence still remains fairly unclear in lots of respects. There isn't an overarching golden bullet adherence intervention that solves all of your problems. But at the same time, I do feel like there should be more connectivity in some of the clinical guidance that's being offered by NICE. So if you look at each individual chronic condition, you'll see that there are sometimes links to the guidance on adherence itself, but very little about how to deal with it in that particular context. And I feel that there's an opportunity there for the NICE guidance to be improved. I also, in terms of that, I've recently written an article on this, but so it's quite fresh in my mind, but I do feel that there's a bit of a disconnect within the NICE guidance on medication adherence itself, because it feels like it's talking about the COM-B model at certain points, but then it sort of lurches back into a fairly archaic view of what adherence behaviors are, so intentional or unintentional adherence issues, which to me isn't quite an adequate way of describing it. So I feel like a lot of the clarity could be improved by just adding that connectivity between the documents, also then trying to update slightly where things have reached in terms of adherence research too. Okay, I'll just dig around for another one. Okay. During the talk, you briefly mentioned adherence monitoring and self-reporting of medicine taking being inaccurate. What other ways are there of monitoring a patient's medication adherence? There are lots of ways of monitoring adherence. It's just a lot of them are fairly unethical or expensive. And so we've been using, for instance, in terms of storing someone's eye drops in a medicine event monitoring system, which is effectively a pill box with an electronic sensor in the lid, which monitors when it's opened and closed. And that is trying to give you a proxy measure of people accessing the medication. And these are largely imperfect as well, because they are not exactly the medicine going into that body, but they do act as a much closer proxy than somebody telling you that they've taken their medicine. I say that whenever there's been these two systems working in tandem with each other, so an event monitoring system and a person telling you what they've done, one is always disconnected with the other. They're not telling you the same thing. So there's many reasons. I don't think patients are lying, but there's definitely a need for understanding what's going on. But I do feel that that can be achieved through dialogue as much as you can be through any new technology. Okay, another one here. How important is it for a pharma company to make medicine palatable in order to have adherence? I think obviously it depends on what's being taken in terms of the medicine. It feels to me that it's as important a barrier, like I said, as anything else, and it could be indeed the most important barrier for some people. Like I say, having a pill that's too large to go in someone's throat makes it difficult to swallow. It can be a very impossible task, and likewise, the glaucoma medication that is unpalatable to people's senses when it goes into the eyes is a major problem in terms of ophthalmology. So having that sensory experience being a positive one is going to be a lot better than having it being a negative one. I'm not quite sure why it would be necessary for a pharma company to make it palatable in other contexts, but certainly in this one, in terms of dentistry, where oral medication is being used, I certainly, if it's possible, can see no reason why anyone wouldn't do that, because it just seems to be an unnecessary barrier. I hope I've answered all of these correctly, but like I say, feel free to get in touch with me if there's anything else I can do afterwards. I'll just scroll back up. You briefly mentioned patient pamphlets. With COVID, we have cleared these away. Do you think that we should now be more proactive and pass them at the reception along with the prescription? I'm assuming that it's safe to hand out the pamphlets now, so I would definitely recommend doing so. I mean, obviously that's not the be all and end all of the situation. There should be some communication at the point of the prescription being handed out, I would have thought, outlining what it's for and how it should be used and so on. I don't know if that would be being done by the dentist in a different room or at the reception where this pamphlet's handed out, but I certainly don't feel like a pamphlet on its own is enough. And at the same time, there's great value in giving something to a patient, because the stress of receiving news of a chronic condition can be a little bit overwhelming sometimes. And having something to refer back to afterwards has been reviewed very positively by the patients I've interviewed. Okay, I think Yeah, there's one more here I can see. My practice was a contract reform prototype. We have been identifying our patients into red, amber, and green status for carries control. Do you think this traffic light system is useful in having patients better understand their situation to help with adherence? Yes, I do, in short. I mean, I've seen different statuses in terms of the RAG statuses and various other ways of categorizing patients. I think it's more practical probably from a clinical perspective than it would be useful from sort of my perspective, I suppose, because I think what we're looking at here are more sort of flags to just alert clinicians to potential behaviors that may need to be addressed. And I think that in and of itself is a very important thing that needs to be done. To me, obviously, I like zooming in and getting into the real complexity of things. And so any sort of three-tiered thing, I don't think has enough tiers. But at the same time, pragmatism will prevail, I think. And I think just any kind of system which will alert a clinician to sort of filter their time a little bit better and choose their battles to fight, I think that's going to be helpful going forward. It's certainly something we're looking at in terms of electronic patient records in ophthalmology. I think those are all the questions that I've had. So unless there are any more coming through, oh, hang on. Have you come across someone with over adherence of medicines like cough syrup? I've come across people over adhering with a lot of things, to be honest with you, including not so much cough syrup. I've never really studied anyone taking that. But in terms of, like I mentioned, the medicine event monitoring system bottles we were using in one of our studies recently, and that allowed us to monitor if people were using indeed the bottles, that when people were doing so. And occasionally you would see patients who would take their drops in a very routine way, overdosing every single day. And glad we managed to intervene at a certain point. Luckily, the eye drops aren't overly dangerous, but at the same time, it's indicative, I think, of a fact that people do over adhere too, as well as under adhere, and that is part of the adherence issue. Is the fact that over adherence can cause sometimes as many problems as under adherence. It depends obviously on the condition that you're talking about. I think that is all of the questions that I can see have come through. So on that basis, unless I see one come through in the next 20 seconds, I think I'm going to wish you all a lovely good night. Thank you all for attending. It's been a pleasure talking to you. I hope it's been of some value. Like I say, if there are any questions beyond this that I can help with after the talk, I'm sure the organisers can provide you my contact details. I'm fairly easy to get in touch with, and I'll do my best to answer you in that setting too. But thank you for tonight. I've really enjoyed chatting to you, as lonely as it's been.